Hello, ladies and gentlemen. Welcome to HAS 20 Virtual Summit Breakouts. During this session, you'll be able to submit questions and upvote questions from other attendees. The questions with the most votes will most likely be among the questions asked by the host to the presenter at the end of the session during the live Q&A. The bottom right tile box is where you can type in your question as well as click the thumbs up button to upvote a question. During the session on the top right tile box, you will also see a 5-question quiz based on the speaker's content. Enhance your learning by taking the quiz during the session and get points for your correct answers. All sessions will be available on demand, and if the presenter has given us permission, you will also be able to download the slides. It is now my pleasure to introduce Session 6, Data Quality, the Bane of Every Improvement Initiative, 5 Lessons Learned from COVID-19. It will be presented by Dan Heinmiller, Vice President of Operations, Application Suite Business Unit, Health Catalyst. Enjoy the session.
Welcome. I'm really looking forward to talking to you today about data quality and some of the lessons we've learned when it comes to COVID-19 and how we can take those lessons and apply them to your organization. So today's agenda, we're going to review some learning objectives, some things that you should be able to do by the end of this presentation. We're going to talk about some data quality challenges that COVID-19 highlighted, but aren't necessarily limited to just COVID-19. We're going to level set and review the levels of data quality. We're going to review some lessons learned from COVID-19 and some data quality challenges that those present. And finally, we're going to discuss how a framework approach will prepare organizations for the next urgent analytic use case. While it might not be COVID-19 or COVID-20 or might not be at a pandemic level, there's going to be another urgent analytic use case within your organization. So by the end of this presentation, you should be able to identify unique challenges that COVID-19 surfaced for data quality. You should be able to discuss levels of data quality, define those levels of data quality, and have some examples for those. You should be able to discuss a systemic approach to data quality, and finally interpret how a data quality system will prepare organizations for that next pandemic experience. Some background information. So what was so different about COVID-19? So the urgency at which data was needed. New reports were being requested, new value sets were being introduced, and updated lab codes were being introduced into the system at a breakneck speed. We also had constraint around resources. Resources were dealing with furloughs, reductions in force, report requests were coming from all over the organization, and you had resources working from home who hadn't traditionally worked from home, potentially dealing with children who were in daycare or school 2 weeks ago. You also had individuals at organizations who were coming down with COVID-19 themselves or dealing with loved ones who were. And what this equaled out to is a reduction in the number of resources that could meet these analytic needs. Along with that, the scope and variety of data was changing as research and needs were expanded. So we had to deal with orders, with medications, administration data, lab codes. There's all of this different information that was coming and needed, and it was at such a frequency that if you weren't staying up to date, if you didn't have that capacity, you were going to fall behind. So we're going to walk through an example from the CDC of some of the, just one example of guidelines that they released. Isolation guidelines for persons with COVID-19 not in a healthcare setting. Simple guidelines, 2-page in length, but the interim guidelines, the first guidelines were released in March 2020, and it was specific to just home isolation. In about a month, it was actually about 25 days later, in April 4th, they expanded those guidelines to just really anybody that's outside of a healthcare setting, but self-isolating. About a month later, they removed some of the guidelines and updated them to now a symptom-based strategy, and they were adding a time component to isolation for anybody that was asymptomatic. So you started hearing about, well, if you're asymptomatic, you're home isolating, maybe you need to isolate for 14 days or 21 days. And they were updating guidelines in accordance with that. And finally, in May 29th of 2020, the information, the research was updated to where they realized that there is viral shedding way beyond what was initially thought. And so they updated the guidelines accordingly. So why would this matter? If I'm a care manager, if I'm a resource that is working at a desk and I have home patients, I have individuals that I'm reaching out to that our organization has stewardship over, I might need to convey the most up-to-date information. I might need analytics that help me identify when was this patient diagnosed with COVID? How many days has it been? How many days have they been in home isolation? And as these guidelines update, and this is just one, and it was updated 4 times in the span of 3.5 months, if I have this urgency, the resource and scope challenges that I highlighted, it's going to be very hard to be agile and responsive to these types of challenges. So some additional background information. The urgency, variety of data, and lack of resources highlighted how it is essential that data quality prerequisites for any analytic use case. Just-in-time data quality or just good enough data quality no longer meets the data quality requirements. So organizations don't know what the next pandemic will look like. We don't know what the next analytic use case could be. But when we issue surfaces, organizations need to be ready with trusted data that can be leveraged for an analytic response. So we talked about looking at the 4 levels of data quality. Before we go in to a healthcare setting, I first wanted to take a look at an automobile setting. So if we think about data quality, it's difficult to move to very complex levels of data quality if we haven't first addressed structural data quality, just the simplest, basic forms of data quality. So think of data quality in a car assembly line. We don't want to inspect the data quality of the vehicle as it drives off the assembly line or the first time a potential customer gets in it, or as we take delivery at a dealership. We need an ongoing process to monitor quality. So we need to ensure that the components, the bolts, the welds, the panels are all of a high enough caliber. We need to ensure the components work and they work well together. So does our tire inflation system and monitor system work? Does the AC work? Does the heat work? Does the horn work? Does our monitoring system, the computer, is it able to read the tire pressure? Is it able to read the climate temperature? Is it able to read the early warning detection system? Do these systems work across with one another? And how do all of these components come together to define the overall experience? So think of a car and driver review or feedback from a customer. They're not reviewing, man, that tire pressure sensor works great. They're talking about the feel, the experience of driving that vehicle. So anybody that's been in a Six Sigma class, you can think of the Toyota Total Quality Management approach. So we're not going to do a lesson on what the Toyota Total Quality Management approach entails. There's plenty written out there about it. But some key points I want to bring up is that they view quality is customer-centric, and it's integrated into all aspects of the business. There's few interdepartmental barriers. It's not one department's job. All aspects of the firm are a part of the total quality approach. So think about your organization. How would you approach data quality differently if everyone saw their role and their department as integral in the overall data quality of the organization? So it's no longer the job of a single resource or a single team. And accountability doesn't fall on that one team, it falls on everyone. Would you see large variances? And also, could you see innovation at unexpected places within your organization? Is that innovation already happening and just not being recognized at pockets of your organization? So let's go back into healthcare. Let's now take those 4 levels of data quality and start talking about them and how they would apply to the healthcare data that we generate and that we utilize to create insight. So we touched on these in the automobile example. The bolts, the welds, that's structural. The tire pressure system, that's a single subject area. That tire pressure system being able to talk to the monitoring system, that's when we start talking about the multiple subject areas. And utility is the idea of that overall experience, that car and driver review. So when we talk about structural data quality, we're talking about database constraints are enforced in including data types, nulls, primary keys, and referential integrity. Often what people think about when they think about data quality. So there's no February 30th. Encounter ID is unique. When we think about primary care physician, PCP, it's a one-to-one relationship for that patient. So single subject area. This is, are the values reasonable within the context of that domain? So respiratory rate isn't negative. The temperature makes sense given the unit of measurement. If it's Fahrenheit or Celsius, it's on the right scale and it's in the right measurement. Multiple subject areas. So values are reasonable across multiple domains. So heart rate is appropriate, but it's appropriate for a child versus an adult. Or the flow sheet recorded date, the observation data, is within the encounter. Somebody hasn't incorrectly keyed in a value of 12/31/2099 when the encounter was discharged last week. And finally, utility. Do the values represent information empirically demonstrated to support better decisions? So respiratory rate predicts short-term mortality and drives inpatient admission decisions. Or think about readmissions or readmission predictive algorithm. And we have 15 different objects or data points that help us determine how likely a patient is to readmit. And as we build that out, we start looking at the accuracy of that algorithm. And we have an expectation for its performance. But over time, we see it start to miss its prediction, starts to get less and less performant. Well, that might be indicative of a data quality issue with one of those objects that is feeding that prediction. And that can be a utility use case that helps us identify that issue. Another example is NASH. So NASH is a liver disease, and there is a relationship. If you have a NASH diagnosis, there's an expectation that you have a specific type of lab and a specific type of procedure. So if I'm looking at aggregated data across multiple systems, one thing that I can do that would be a utility data quality check is look for all my NASH patients and how often am I seeing that lab? How often am I seeing that procedure? So taking all of this into consideration, the 4 levels of data quality, what I want to move into next is looking at data quality and some of the lessons learned through the COVID-19 pandemic. So the first lesson I want to talk through, lesson number 1, is that we need to assess data quality throughout the pipeline. Today, data quality may be on the backs of your analysts or addressed only at the end of the pipeline. Each data quality issue is accompanied by a root cause analysis. So someone goes to turn in a report, a data quality issue is identified, and then that kicks off a root cause analysis, and we go back and we try to figure out where was that introduced. That takes a lot of time, that takes a lot of energy. All right, so the example that we're going to look at today is that a report is getting delivered, and as this is getting printed out for COVID-19 patients, so that individuals can start contacting their PCP with their permission, we find out that it's not one PCP listed on the report, but every PCP that this patient has ever been assigned. The report writer knows this should be a one-to-one relationship, not a one-to-many relationship, and starts and kicks off a root cause analysis. Well, ultimately, after a lot of time and a lot of energy, they find that this issue was discovered here, but introduced here. And the cause, and I can speak from experience, I think I've done this myself, is that when the tables were joined, they didn't include a time component. They didn't say, give me the PCP at this moment in time. They just joined to the table and said, give me the PCP, and so every single PCP was returned. But what if we didn't wait until the end of the pipeline to discover that that issue was present? What if we could instead put a data quality check on top of that data mart, on top of that model, so that as soon as that one-to-one relationship is broken, it kicks off a data quality alert. Taking that same concept out slightly, why not build data quality checks not at the end and not where they've been introduced, but anywhere where a model is being built, anywhere where data is being delivered? So now, instead of only thinking about data quality at the end of the pipeline or at the start of the pipeline and only thinking of it through a structural lens, we can use the pipeline in different checks on each component to find what are the most common data quality challenges that we have or that could potentially get introduced in that domain. So the next lesson I want to talk about is that you don't want to leave your analysts to firefight. So when you don't have a systemic approach, data quality assessments, monitoring, firefighting issues falls on the backs of your analysts. You might think that you don't have a data quality challenge at your organization. It actually might be that you just have some really strong analysts that take it upon themselves to make sure that these data quality challenges aren't being put in front of your end users. So COVID-19 caused resource shortages due to furloughs, the resourcing challenges, the influx of report requests. An analyst and a customer can define data quality requirements, but should not be the data quality solution. So your SMEs, your report writers, your business users, they know what good quality data looks like, but they shouldn't be the ones of coming up with a systemic approach. They shouldn't have a one-off solution, a desktop solution, an Access database, an Excel document that they utilize to clean up all the data before it gets delivered. Analysts should instead focus on defining the data quality for their use case, not reinventing the infrastructure. So if we give them a structure to work inside of, we can take it off their backs to where all they have to do is actually do the analytics work that we're asking them to do. All right, for lesson number 3, let's talk about looking outside of your 4 walls. So we're talking about verification and validation. So verification, does the meta constraints, are they met? Do we meet system assumptions? Do we have local knowledge represented in the data? Validation focuses on the alignment of data values with respect to relevant benchmarks. So this isn't something that can be done at a moment's notice. And it takes forethought and planning. And there's a reason that you can't wait until the urgent need comes to do this comprehensive data quality check. Say you're an organization that is doing mergers and acquisitions, and you're bringing in new clinicians, you're bringing in new health systems, you're bringing in new hospitals, new clinics. It makes sense to compare the data quality as it already exists to the data quality of the data you're about to bring into your organization. So that's the first screenshot we have below. We have a normalized distribution of gender codes, and we have expected values, female, male, unknown. And then we compare the known values to a health system or to a hospital that we're about to bring into the data, and we see that they haven't properly normalized. They don't match our expected values, and they don't meet that referential integrity that we need, and we can address that data quality alongside them. And the second screenshot, this is a little different, and say you're a health system that has many hospitals, say 10 hospitals, and you want to compare the data quality across all 10 of those hospitals. Imagine you have a field like age number description. And at 9 of those hospitals, your fill rate is at 100%. And at 1 of those hospitals, your fill rate's at 0%. Well, when you go to look at your overall fill rate in the aggregate, it's going to show 90%. You might say, well, that's good enough. That makes sense. Directionally, we can tell where our age fall. We accept that 10% might be an okay null rate. But when you break it down and start comparing the individual hospitals as opposed to the entire health system, we find out that 9 have 100% and 1 has 0%. And that's where this distribution comes in. So rather than just looking within the single health system or that single hospital, we want to compare the individual institutions against one another. And just by getting it on a simple whisker box plot like I have here, the variance of the whisker plot itself might indicate a data quality challenge. But here I can see that for my first value, that this health system, this hospital, falls outside of my acceptable range. And that the last value, my blank value, also falls outside that acceptable range. So this would be a data quality challenge that I would want to address. And I wouldn't want to wait until the data is already part of the aggregated data set. I'd want to get it addressed with that individual hospital. The next lesson I want to talk about is that context and purpose matters, especially when you're trying to determine whether data quality is sufficient to support decision making. So there's certain things like we talked about structural data quality. So just a reminder, that's the database constraints, the data types, the primary keys, referential integrity. So one example of structural data quality is admit date. So that shows in hexadecimal. Have you ever used Excel and you improperly format a column? you're expecting a date field and you get an eight-digit value and you're wondering what that is. What it actually is the number of days from an anchor point, an anchor date, and it's just counting the number of days since, but that doesn't really help when we're trying to run analytics. So that's causing issues for reporting. Does the context that we're going to use that date matter? Absolutely not. Does the purpose matter? No. It's just that I cannot read, it's not in a human readable format, and I need to get that structural data quality issue addressed. So next comes a single subject area. So this is where is the value reasonable within the context or subject that we're looking at? So temperatures within a normal tolerance for high and low values. Is it context dependent? No. Is it purpose dependent? Again, no. But it does require some level of subject matter expertise. My data quality resource, my person monitoring data quality might not know, well, they might know a reasonable temperature, but they might not know what a reasonable range is for A1Cs. We might need to bring in subject matter expertise to help us define that data quality check. Next, we move on to multi-subject area. This is where values make sense when viewed across multiple subject areas. So recorded heart rate takes place during an encounter, and it is within normal tolerances. I'm not looking at observations associated with an encounter and seeing one again in 12/31/2099. Or somebody miskeys in and I'm getting a 1990 date for an observation that should be associated with an encounter that took place last week. So does context matter here? Yes. Is it purpose dependent? Does it matter how I'm using the data? No, it does not. But again, I might need subject matter expertise, but I might need subject matter expertise across multiple areas. So that might be a business resource, a financial resource, a clinician. There's a lot of different SMEs I might need to bring to the table to help define this type of data quality. And finally, we move to utility. So this is the values represent an empiric value to help support better decision making. So temperature is shown as a good indicator for symptomatic COVID-19 and should be considered in any predictive algorithm. So does the context of the data matter here? Yes. And does the purpose of the data matter here? Oh, again, yes, because we're using it to help a prediction. The purpose that we're using that data is part of the definition of the quality level that we need to ascertain. So this is going to help require and drive analyst engagement. We're going to have to probably bring in multiple SMEs. We're going to have somebody that understands the model and bring all of those resources together. And the final lesson we're going to review today is that a singular vision is key to scaling data quality. So you need to get buy-in on a singular vision to be able to scale this. COVID-19 has shown that beyond structural data quality, the insights that analysts and clinical experts bring to the table have to be integrated into a framework. We need to pool investments that have been traditionally disparate across an organization to achieve economies of scale. So a lot of organizations, you have resources in different departments that think about data quality, but it's 5% of their job, 10% of their job, 15% of their job. If all of them are out there in their individual departments thinking about data quality, are you ever going to achieve scale with only 5 to 10 to 15% investment in those different areas? But if we're able to pool those, if we're able to create a single vision, if we're able to create a bus that we want to get everybody on and create a coalition, well, now we start adding up all those 5%, all those 10%, all those 15%. And now we have everybody facing inward and being part of a single vision. Well, that's something that can scale. And also subject matter insight can be shared much easier with a common approach. We talked earlier about we don't want your analysts to be the data quality solution. We don't want your SMEs to have to address data quality when that report is slid across the table. I've been in rooms where I've had to deliver reports that show negative results, negative numbers, a mortality rate that's higher for one physician versus another. The first thing that they say, that's not my data. Those aren't my patients. My patients are sicker. There's a lot of different ways they can push back. If you don't have confidence in the data, the next thing you're going to do is you're going to spend 2 to 3 weeks proving out those numbers. And when you come back to the table, you've lost all that time to where you could be improving patient care. You could be reducing variance. You could be increasing your financial footing because you don't have confidence in that data. So we want that subject matter expertise to be driving data quality not at the point of delivery, but help drive it as those relationships are being created within the data, as that structure is being established, as that data is being ingested. So how does this all come together? Let's take a look at what a data quality framework would look like. So if you start thinking about data quality as a product and treat it as a product and treat that quality as it traverses your entire system, that's going to start having this framework approach. That's going to start creating a vision that others can get behind. Next, we want to address structural data quality first before moving on to more complex data quality challenges. So think of utility. Utility is shiny. It can bring a lot of people to the table. We're developing a predictive algorithm that's going to help reduce readmissions. But if we have dates that are out of sync in our calendar, if we have multiple primary key violations, does it really make sense to start with utility if we haven't addressed some of those structural challenges? It's not to say that we have to be 100% and have absolutely every structural challenge addressed, but we should be well on our way and confident enough in the data that we can start looking at single subject area, multi-subject area, utility. So next we want to define a single subject area and multi-subject area data quality use cases alongside those subject matter experts that are using the data. You might not have a financial expert on your data quality team. That doesn't mean you don't have a financial expert at your organization. Maybe you don't have a clinician. Well, you have clinicians that you can bring to the table. Scale their knowledge by bringing them and making them part of the data quality process. Have them help develop unit tests. Have them define what good data quality means to them so that you can look upstream, find where that is initially defined, and then wrap that with a unit test, wrap that with the data quality check. And finally, the most important thing, I think this is what is key to building a framework, you have to create a coalition. Oftentimes, you see things happening organically. It's a grassroots approach, bottom up. You have a lot of people that want to champion data quality, and it fails. People get frustrated. They walk away. They said, well, I'll go back to what I was doing on my desktop. It works. Well, if you don't have a top-down approach, if your C-suite, if your executives, your directors, your managers, if they aren't on board and helping build this coalition and getting buy-in, it's going to be really hard to convince somebody to stop using their Access database that's worked for them for 15 years. It's going to be hard to convince that person to, hey, let's take your process and take those unit tests that you're doing in your Excel document that lives only on your desktop and make this part of a broader coalition, a broader process. What you'll see is that those individuals, that nurse manager that has done that for the past 15 years and it's always delivered good data, the moment that person retires, the moment that person walks away, the moment that person takes another job, your data quality is going to suffer. So let's build a coalition, bring all of that knowledge together, that SME information, and create a single solution that everybody can rally behind. So what are some key learnings and recommendations that I'd like you to take away from this presentation? First, there's going to be another urgent analytic use case in the future, and preparation matters. Let's take what we've learned from COVID-19, wrap it into a process, and ensure when that next urgent analytic use case comes, we're prepared. Finally, data quality must be addressed through a systemic approach that covers the life cycle of the data. We can't think about it just when it gets ingested. We can't think of it just from a structural perspective. We can't think of it just when it's delivered. And we don't want it to be on the backs of the analysts that are delivering that insight. And if you think of the next key learning and recommendation is that just in time is too late for data quality. It might work today because you have capacity. You have all your resources. But COVID has shown us that very quickly we can lose resources to staffing challenges, to financial challenges, to sickness. And so if we're waiting for just in time, eventually that will break down. And finally, the insight that analysts and SMEs bring, it can help shape a robust approach for data quality, but those analysts and SMEs should not be the solution. They should be part of the solution. Thank you, and I hope you'll join us in our Q&A session, and I look forward to hearing your questions and learning from you.